Globally, roughly 17 million deaths are caused by cardiovascular diseases and diabetes each year. Although the major metabolic risk factors for these diseases have been characterized in epidemiological studies, these research makes us understand the effects of metabolic risk factors on cardiovascular mortality and burden of diseases by consistent measurements of the effects by age, sex, and religion. Well, hello everybody, it's Ishita, and today I'll be presenting critical appraisal for research, article, and systematic review. As you can see, the first image on the right hand side, it tells us that there are so many fake news. Stop trusting on everything. So, what is a critical appraisal? A critical appraisal is the process of carefully and systematically examining research to judge its trustworthiness and its value and relevance in a particular context. Next, talking about the steps of critical appraisal. The first step, that is clinical problems. Looking for clinical problems. The next comes asking a clinical question. In this case, the paper which I have used, the clinical problem is cardiovascular disease and diabetes. The clinical question is cardiovascular disease and diabetes age and sex specific? Then comes the literature or the evidences. Basically, we can use different engines like PubMed, Scopus, ProQuest, or Google Scholar. I've used Google Scholar for my entire research. Then comes the critical appraisal of the evidence. In this case, I'll be talking about that forward in my presentation. Then comes the integration of evidences. In this case, 123 cohort provided data on 1.4 million individuals, and the result was 52,000 cardiovascular disease patients. The outcome was age group of 55 to 64. The relative risk for systolic blood pressure was largest for hypertensive heart disease. Talking about the research design and participants now. All four cohort pooling studies have large number of participants and events that allow the estimation of relative risk by age and disease outcome. Further, all these pooling studies use individual level data, which allows more consistent adjustment for confounders. The sources used were Asia Pacific Cohort Studies Collaboration, the Diabetes Epidemiology Collaborative Analysis of Diagnostic Criteria in Europe, the Emerging Risk Factor Collaboration, and the Prospective Study Collaboration. All pooling studies included in this analysis adjusted for age and sex and accounted for differences in risk by cohort. Relative risk for both sexes combined because results of the included meta-analysis had shown that relative risk between men and women were similar. Based on prior evidences that proportional effects of some metabolic risk factors may vary by age, a key aim was to establish quantitative estimates of interaction by age. To estimate the overall uncertainty, statistical approach was used. A meta-analysis was published from the normal distribution and standard error. Also, a linear model was used for age-specific results. Talking about the exposures, outcomes, and results now. Relative risk of exposures for cardiovascular diseases used meta-analysis for epidemiological studies. Large comprehensive pooling projects for observational studies that estimated the effects of baseline or usual exposure for the risk factors and outcomes of interest by age group was selected. Even though randomized studies were available, but observational studies were used because they estimate the effect of risk factor levels on disease outcome as opposed to the effect of a particular pharmacological intervention, which may act through risk factors reduction as well as pathways. Second, they estimate the long-term effects, sometimes over years or even decades, of exposure to risk factors as opposed to effect of short-term changes due to treatment in randomized trials. And lastly, they generally have larger sample sizes and can provide more precise relative risk for more detailed age groups and disease categories. However, Randomized trials were used to support the evidences on the presence of causal effects from observational studies. Additionally, an alternative exposure distribution called theoretical minimum risk exposure distribution, which is commonly known as TMRED, was used to measure the effects of the risk factors. Well, the outcomes showed a linear relationship formed between relative risk and midpoint of age in each category. The relative risks were consistent across prospective studies, collaboration, and Asia-Pacific cohort collaboration, except for the estimated effect of total cholesterol on ischemic heart diseases in those younger than 55 years of age, which was larger in the prospective study collaboration. There was a reduction in the relative risk of ischemic stroke with increasing age, similar to that was seen in the systolic blood pressure. Indeed, the 95% confidence interval of the pooled relative risk included the null effect for ischemic stroke in ages 75 years and older. There is an evidence from randomized trials of statins that lowering serum cholesterol in participants with high cardiovascular diseases risk may lower the risk of stroke in those aged 70 years and older. Relative risk for the estimated effect of BMI on diabetes and hypertensive heart disease were larger in Western cohorts as compared with the Asian cohorts in adults more than 55 years of age. Perhaps due to longer exposure to high BMI in Western populations, because there was no association between BMI and hemorrhagic strokes for BMIs up to 25 kgs per meter square in Asia Pacific cohort study collaboration and emerging risk factor collaboration, as well as the prospective studies collaboration. We report the relative risk per unit of BMI above 25 kilograms per meter square pulled from these two meta-analyses. Evidence were pooled on the cardiovascular disease effects of risk factor from observational studies. Therefore, unmeasured and residual confounding cannot be ruled out. This is of less concern for systolic blood pressure and total cholesterol, where there is an overwhelming evidence from randomized trials in antihypertensive and cholesterol-lowering drugs that corroborate the evidence from observational studies on causal effects and their magnitude for BMI as well as the FTG, and confounding remaining as a concern evidence from randomizing trials of diseases outcomes is either very limited for practical reasons or provided mixed results. Well, talking about the conclusion now, I'll be talking about the conclusion of research articles. So confounder is a big problem, as I mentioned earlier as well. However, in this research, observational studies were used and the confounder were adjusted from the pooled evidences. The results were promising and can be believed. Secondly, they can be applied in general population and no potential conflict of interest related to this article was found. Cool. Now let's talk about the systematic review. So I'm going to be talking about the research question and strategy first of all. So the question and strategies both were appropriate in systematic review. Extensive literature searches were performed using search strategies developed by an information specialist. Search strategies were refined and adapted according to the configuration and requirements of each database. The final strategies combined relevant search terms comprising indexed keywords. Literature searches were not limited by date, language, or publication status. Supplementary searches were undertaken in 2 trials registered and conference abstracts from 4 major cardiovascular disease conferences. Meta-analysis was not possible due to heterogeneity in the cardiovascular diseases. Cardiovascular disease outcomes, population, and statistical analysis methods. This review included prospective studies which assessed the relationship between lipoprotein as well as cardiovascular disease outcome. These studies included randomized controlled trials, cohort studies, as well as nested case control studies. Eligible populations were the adults who were greater than 18 years of age, population regardless of baseline cardiovascular disease risk, gender, and ethnicity. Studies had to follow patients for at least 12 months. No restrictions were placed on the no restrictions were placed on the cardiovascular disease outcome or the type of lipoprotein assay. However, studies were required to use a multivariable analytical approach which assessed the effects of lipoprotein on cardiovascular disease outcome after adjusting for other confounding factors. Um, and the author's results were quite promising. Cool. Now let's talk about the exposures, outcomes, as well as the results. Randomized controlled trials, nested control studies, and cohort studies were included. Any adult who is greater than 18 years of age were eligible participants regardless of the gender, baseline cardiovascular disease, ethnicity, as well as the age. The patients were the patients were followed for 12 months at least, as I've already mentioned before. The outcome of the review showed a relationship between cardiovascular disease and lipoprotein. As you can see in this picture, there is a healthy blood vessel, the first one, which shows the blood there inside the blood vessel in a red color. And then we can see that how the lipoprotein, also known as bad cholesterol, is building up inside the inside the arteries, and how that yellow color is replacing the red color of the blood. And slowly the lipoprotein is increasing, and eventually on the fourth artery, you can see that it is filled with lipoprotein. And that is the reason why heart attack happened to this person, and it also damaged the area after heart attack. Cool. So that was about the exposures and outcomes. Now let's talk about the results. And I'm going to be talking about PRISMA. So literature searches of electronic databases and other sources, including hand screening, hand searching, retrieved 3,837 abstracts through December 2015. After deduplication, a total of 2,850 articles were screened and 2,189 papers were excluded as having no relevance to the review. Full papers of 312 potentially relevant references were selected for further examination. Of these, 197 papers were excluded. After further examination for the following reasons: do not report relevant prognostic papers. Those were 20 papers. And there were 32 papers who did not show any relevant outcome. Out of that, 103 papers were not related to the study design, which they were doing. And there were 42 papers who clearly reported no multivariable analysis. A total of 60 studies, which included 115 papers, met the criteria for the inclusion in this review. So a total of 60 studies was used in the systematic review. Well, that was all about the exposure outcomes as well as the results. The conclusion was that the results are believable, and the confounders were adjusted, and these results can be applied to the general population, and there was no conflict of interest. Cool. These are a few references which I was able to find, especially with a research article which I studied, as well as the systematic review, also the sources which I have used, and the collaborations which were used in the research article. All good. So that is all, and the different collaborations were used. Well, thank you so much for listening to me today. And lastly, I would like to say that stay healthy, and that is the most important thing to avoid any diseases and especially cardiovascular diseases as well as diabetes. Eat healthy, stay away from any kind of junk food. And well, thank you so much for giving me an opportunity to do this presentation today. It was an amazing topic, and cardiovascular being my favorite topic. I got a lot of insights about cardiovascular diseases as well as diabetes. Take care. Bye bye.